Right, they'll be coming in. Good evening and welcome to the Myasthenia Gravis Association virtual monthly meetup. We're glad that you're here. I'm Catherine Clemens, Community Program Coordinator for the Myasthenia Gravis Association. This evening, I'm joined with Brian Bosch, MGA volunteer, who will assist me in monitoring questions and feedback. If you're new to the Myasthenia Gravis Association, we hope you'll check out our website at www.mgakc.org for additional programs and events happening. If you're newly diagnosed, please email us at info@mga.kc.org. That's info, I-N-F-O, @mgakc.org to obtain a new patient packet. For our September virtual meeting next month, we will be meeting on the third Monday instead of the fourth Monday of the month, so mark September 16th on your calendar. We'll have more information coming out via email soon. Tonight, we're excited to welcome Angela Pepin with Prompt Care to share more about IVIG. Angela will let you take it from here.
Hi, thank you. I'm excited to be here. Thank you for inviting me. I've really been looking forward to meeting with everyone. So I'm going to take a moment to share my screen. All right. Okay, as Catherine said, my name is Angela Pepin. I work with Prompt Care as the Director of Clinical Pharmacy Programs, and I am a Certified Specialty Pharmacist. At Prompt Care, in my role, I work with a lot of different therapies, specialty infusion therapies across a wide range of disorders and disease states, including myasthenia gravis. Work with a lot of IVIG here as well. So the only other thing I wanted to mention before getting started is that today we're going to be discussing the use of IVIG and myasthenia gravis really in general terms, with the understanding that only your prescriber and your healthcare team is going to be able to evaluate you as an individual to really determine if IVIG is right for you, and if so, how it should be used. So that's just something to keep in mind as we go through the information on these slides. Sometimes it'll apply to you, and sometimes it may not. So ask your provider with any questions. All right, so digging right in, the goal tonight is really to understand the use of IVIG in myasthenia gravis and become familiar with what it looks like to receive IVIG. To do that, we're going to first start by just an overview and review of some of the processes within the body that are going on to cause the symptoms of myasthenia gravis. Then we'll get into discussing IVIG in the context of what it is, how it's made, how IVIG works in myasthenia gravis. And then we'll move on to take a look at how it's administered, and we'll discuss potential adverse effects, side effects, and also ways to prevent some of those things from happening and potentially troubleshoot some of those issues to try and overcome them and continue on therapy whenever we can. Finally, we're going to end with discussing how IVIG products can vary from one another and what that means for us. All right, and at the end, of course, we'll just summarize some of our key points. Okay, so brief overview, very high level. We know myasthenia gravis is a chronic autoimmune neuromuscular disorder. With autoimmune meaning that the body's immune system is attacking the normal healthy tissues or proteins that we actually need in order to function normally. And then neuromuscular is referring to the targeted effects on the body's nervous system, as well as muscular system, which normally work together to create movement. So in myasthenia gravis, the muscles controlling the movement of the eyes, face, limbs, so your arms and legs, neck, throat, all of these can be affected. And ultimately, the symptoms we see are caused by the degree of muscle weakness at the site being affected. So looking a little bit more into some terms we may hear, including antibodies and autoantibodies. So normally our immune systems identify foreign substances and produce proteins called antibodies that attack and eliminate the things that don't belong. So like bacteria, viruses, or unhealthy cells. But as we discussed, in an autoimmune condition, the immune system is mistakenly kind of flagging tissues and materials that are normally there, and is telling the body, hey, we need to get rid of these, and it's producing antibodies against us. So in this case, we're calling these autoantibodies. So autoantibodies in myasthenia gravis are typically going to be against acetylcholine receptors. In fact, up to 90% of myasthenia gravis individuals have the autoantibodies, which block the receptor for ACHC and ultimately prevent it from transmitting the message from the nerve telling the muscle to contract. There are other causes as well. So autoantibodies can be produced that attack muscle-specific kinase, as well as some other autoantibodies that disrupt the neuromuscular junction, which is again where the nerves meet the muscles and communicate between the two to create movement. There are other immune mechanisms as well, but those are outside of the scope of what we're discussing today. Okay, so for those of us, if you're like me and you're a visual learner, this graphic basically illustrates the words from the last slide. So on the left, you can see in a normal functioning neuromuscular junction, there's this the yellow part is the neuron, and you can see it's releasing the neurotransmitter acetylcholine, which is represented by the little reddish pink dots. So the neuron is releasing the message, and it's transporting the acetylcholine to the little receptors on the muscle. So those upside down blue cups are representing the acetylcholine receptors. Normally, the acetylcholine binds to that receptor and delivers the message, okay, muscle, it's time to contract. In myasthenia gravis, on the right, you can see that the nerve is still releasing the neurotransmitter, but what's different here is there's the autoantibodies in the system, and that's represented by the green colored upside down Y shape. That autoantibody is blocking acetylcholine from attaching to those receptors. It's also attacking those receptors as well. So ultimately, we're not able to communicate from the nerve to the muscle that it's time to contract. Okay, so how do we treat myasthenia gravis? In terms of medications, generally it can be divided into treating symptoms directly. There's also long-term immunotherapies, including steroids, and also the non-steroidal immunosuppressive drugs or medications. And then last of all, there's what we consider rapid immunotherapies, which include plasmapheresis, and then in the context of our discussion today, includes IVIG. So IVIG stands for intravenous immunoglobulin. And in terms of immunoglobulin, there are 5 different main classes of IG or immunoglobulins, with IgG being the major component. In fact, approximately 80% of our immunoglobulins are composed of IgG. So our immune systems naturally make these proteins, like we said, in response to a wide range of factors. And the Ig from our plasma can be pulled from healthy donors and then made into a final product that closely resembles human plasma. It can then be administered intravenously or through the vein. you may wonder a little bit about how IVIG is produced and really whether it's, sometimes people ask, is it safe given that IG is pulled from plasma donors? So I just wanted to go into a little bit of detail here and note that the process requires obtaining plasma from a minimum of 1,000 to 10,000 healthy donors volunteering. And the procedure itself results in a highly purified product because they have so many rigorous safety protocols. So beginning with a strict and thorough screening process of donors. And then once the donor has donated the plasma, the individual sample is tested for any infectious agents before it's added to any other, pooled with any other samples. So it's screened for example, HIV, hepatitis A, B, and C, and other infectious agents as well. So if it passes that test, then it's pulled with other samples, which then again, the pooled plasma is also tested as well as undergoes purification processes and viral inactivating steps throughout the process. So ultimately, at the end, plasma is filtered to separate out the IgG molecules. And if it passed all the final tests, then it's provided as a product for administration. So according to the package insert or the prescribing information from these medications, they all carry with it the warning that because this is a blood product, there's inherently a risk for the risk of viral transmission or transmission of viruses. But then if you look at it, there's actually 0 documented cases of infection transmitted by IVIG since the purification process was really established over 40 years ago. So theoretical risk, but many safeguards in place, and we haven't seen any transmission of infectious agents in over 40 years since they've perfected this process. So what do you use IVIG for? It's not only used for myasthenia gravis, it's actually used in a significant number of other disorders. Like I said, we use it a lot here. I see it used for many different uses. It's FDA approved for various conditions, which I've listed here. But overall, we see it used in immune deficiencies, inflammatory conditions, and autoimmune conditions, which we classify myasthenia gravis as, with some overlap in other categories as well. So the use, a quick note that there's not any specific IVIG product that includes in its official labeling every single use that IVIG is used for. So I just wanted to note that the use of IVIG in treating symptoms of myasthenia gravis is studied by prescribers. So the exact mechanism of IVIG is unknown, but it's thought to work by providing anti-inflammatory effects. It works by suppressing or decreasing the production of those autoantibodies. And then it also works by neutralizing and helping to destroy the autoantibodies that are blocking the acetylcholine from communicating with the muscle to contract. So here are some examples of when IVIG would be used to treat myasthenia gravis. So for exacerbations, it can be used in patients that are refractory to other treatments for myasthenia gravis. Sometimes IVIG can be used on more of a long-term basis as long as it's effective for them. It can also be used as preoperatively before a thymectomy sometimes. And then we also sometimes see it used as a bridge therapy to slower acting therapies. So for example, some of the immunotherapies can take months to produce a full effect. But IVIG, on the other hand, can really start working within a week. So while we're waiting for the effects of those slower acting therapies, IVIG can be a great way to provide relief of symptoms right away. It really lasts only about 3 to 6 weeks. It's highly dependent on the individual and various factors. So occasionally if a patient is on ongoing IVIG, they need to be redosed after about 3 to 6 weeks. All right, so let's look at how you administer immunoglobulin. We talked about giving it intravenously or through the vein. That's really the most common way we see it used in myasthenia gravis. And like I said, we use it kind of on a one-time basis or as needed for symptom exacerbation, or occasionally we'll see it used more chronically. I did just want to make the note in case you're doing any of your own research and come across subcutaneous immunoglobulin. This is also a way that it can be administered. It's an infusion delivered to the layer of fat beneath the skin, but we see this more commonly in indications that typically use this on a more chronic basis. But I did just want to note that that is out there as well. IV infusions for IVIG can be given in multiple settings. So that's a great thing about it. It can even be given in your home or an infusion suite or your doctor's office, an infusion center. And of course, it can also be given in the hospital if you were to need it in that setting as well. So the environment that you get IVIG in may change, but it's always going to be given by somebody trained to administer it, most often a nurse. The infusion itself is divided over 2 to 5 days, more often over 3 to 5 days of daily IV infusions. And this is because the dose that needs to be given to exert its effect, if it were to be given all at once, it could be really hard for the body to tolerate. You could have unacceptable side effects. It could also increase the risk for certain adverse effects. So giving it more slowly, divided over the course of a few days, can really make it more tolerable. It also can, like I said, decrease side effects as well. So each infusion is going to be dependent on the dose and how you tolerate the infusion. But each infusion generally lasts a couple hours. I also just wanted to make the point that depending on who's providing your therapy, you may see it administered in different ways. So your provider, your nurse may use an IV pump, or they may use a gravity infusion set or rate-controlled tubing. It kind of varies, but there are multiple very safe ways to give IVIG, and it can be dependent on the protocol of the provider, and then also sometimes just based on the patient needs as well. So looking at side effects as opposed to adverse effects, just to define the two or kind of differentiate them, side effects we think of as being more predictable responses to medications. They're usually not desirable, but on the other hand, adverse effects are more unexpected and they're always considered harmful. So for IVIG, looking at side effects, systemic reactions are not uncommon. So don't be scared away by this. You can read that up to 40% of patients will experience systemic reactions, especially with like their first few doses. But most of these reactions are really mild and self-limiting. You can have commonly tiredness, so fatigue, headache, fever, and then mild flu-like symptoms, so general aches and pains, kind of just feeling tired and worn out in the hours or maybe the day following your infusion. There's absolutely things we can do to try to prevent those side effects, with hydration being a very important one, making sure that the infusion is given over an appropriate rate, so not too fast. And then those side effects can also be managed a lot of the time with, besides hydration and rest, things like acetaminophen or diphenhydramine over the counter, as long as your prescriber says that's something that's okay for you to take. So adverse effects, as with all medications, come risks, and IVIG has some important ones that you just need to be aware of. So the potential risks are renal failure or kidney failure, something called aseptic meningitis, thromboembolism or blood clots, and in rare cases, well, all of these are rare cases, but last of all is anaphylaxis. So to give you a little bit more information about some of these super rare adverse reactions that you really need to be aware of in the off chance that they occur. First is aseptic meningitis. It has an incidence of approximately 1 out of every 1,500 infusions, so around 0.067%. And in these cases, what it is, it's inflammation of the meninges, which are the layers protecting your brain and spinal cord. And it seems to be caused by a rapid shift of fluid and antibodies into that fluid within your your central spaces, so within your brain and within your spinal cord. And so most often these symptoms can present after 48 hours of infusion, but they can present as early as 6 hours or up to 7 days after the infusion. Symptoms of this would be a very severe headache, nausea, vomiting, trouble moving your neck, so nuchal rigidity, pain upon trying to move your neck, also light and sound sensitivity, so kind of extreme migraine symptoms here. So if that's abnormal for you, or that's something that's going to require emergency medical attention, they're just going to want to rule out other causes of the symptoms to make sure they're treating the correct cause. And then once you're diagnosed with aseptic meningitis, it comes down to a matter of hydration, medications to help with the nausea, steroids to reduce inflammation, and then pain medications that you take by mouth to help control the pain associated with the headache. So acute kidney failure is another risk. Again, this is rare and seems to be associated with individuals that are already prone to kidney disease or already have kidney disease. Also older patients, if you're dehydrated, this puts you at risk. So it's very important to stay hydrated before your infusion and after your infusion. Diabetes, other drugs or medications that can be harmful to your kidneys. So always make sure you give a full list of your medications to your pharmacist or prescriber. And then I did just note sucrose stabilizer, since that's commonly referred to as a cause of kidney injury with IVIG. However, no products in the US contain sucrose any longer. So symptoms would be, if you're not urinating as frequently, increased heart rate, swelling in your legs and lower extremities, the legs and feet, and then sudden confusion can also be a symptom. So blood clots are also listed in the prescribing information by the manufacturer as a risk. Potentially, there's different thoughts on what about IVIG increases your risk for a blood clot. Some of the thoughts are that it can increase the thickness of your blood. It could also release some inflammatory substances, but ultimately it seems to really be related to patients that are already at higher risk. So again, just allowing your provider to get a really thorough history of your health is important, so that they can help decide which product is right for you. Make sure that it's not going at too fast of a rate if you're at risk for this. So really just important to make sure your provider has all the information. All right, so I've said several times that prevention for some of these side effects, hydration is really key. And it's well known that hydration can really make or break a patient's experience with IVIG. So really, you don't want to wait until the morning of your IVIG infusion to start hydrating. You want to really focus on increasing your water intake in the days prior to infusions, and then after the infusions as well, continuing to give your body all the water it needs is really important. IVIG is full of these large molecules that can cause shifts of fluid in different compartments, and drinking plenty of water kind of helps prepare your body and can prevent some of the side effects like fatigue and body aches and pains. And then it can also help prevent the severe, more rare adverse effects like meningitis, kidney problems, and blood clots. Also, being well hydrated is appreciated by nurses, I know, for helping them start IVs. What's next? So next we have just a reminder to communicate with your healthcare team, making sure that we have a complete health and med history. And then anytime there's a change in your health, any new diagnoses or medication changes, again, communication is really important. If you're prescribed pre-medications, which are medications that your doctor may say, okay, I want to make sure that, you know, whatever problems you had with your infusion in the past don't happen again, I'm going to give you a corticosteroid or an antihistamine prior to your infusion. If those are prescribed, really try to be adherent and take those medications. And if you are late taking them or were not able to take them, make sure you're communicating that with your infusion nurse. So during the infusion itself, you should expect and accept any clinical monitoring provided by the nurse. They're going to be checking your vitals. They're going to be asking you assessment questions to determine how you're tolerating your infusion. It's really important that the nurse ask these questions and that you answer clearly, because this is what's going to guide them as they continue to titrate the rate up. They should always start slow and then gradually increase the rate based on how you're tolerating the infusion. The first infusion is pretty much always the slowest infusion because we're just really cautious to make sure that we're not going to give you a bad experience with IVIG. So it's a slow infusion at first, and then subsequent infusions, depending on how you tolerated it, can be a little bit faster. No two patients are going to have the same infusion rate, and it can really depend between patients. So if you have persistent side effects from IVIG, depending on what they are, don't give up too fast. Some of the mild side effects can be helped and prevented and treated, like what we said, with rest and hydration. We can use some of those over-the-counter treatments if it's okay with your prescriber. Just a quick reminder, if you are using diphenhydramine or anything that makes you sleepy, be cautious with any activities. So if you're going to like an infusion center to receive your IVIG and you're taking diphenhydramine as a pre-medication, for example, you want somebody to be able to help you drive home, those kind of things. Other things that can be done, again, looking at the rate, slowing it down, adding pre-medications, dividing the dose is another option. Maybe it was prescribed over 3 days, maybe it needs to be over 5 days instead. And then last of all, sometimes even trying a different IVIG product can also help. No two IVIG products are exactly the same, well, for the most part, depending on the manufactured product, but each of them are a little bit different. So just because you don't tolerate one doesn't necessarily mean you won't tolerate another. So all things to discuss with your provider, and to just keep on the table the potential benefits that IVIG has to offer.
Angela,
we have a question.
Yeah.
Does SCIG pretty much have the same risk and side effects, like the risk of meningitis, blood clots, or kidney issues? Or is there a better option for patients that are at an elevated risk for those?
Great question. So sub-QIG prescribing information contains all those same risks. However, depending on the situation, the sub-QIG provides sort of like instead of getting that peak of IV infusions and then that slow decrease over the course of 3 to 6 weeks, with sub-QIG, you kind of get these little bursts that keep this really consistent amount of IG in your body. So because you're not getting that high peak, just these little boosts, that seems to maybe decrease the risk a little bit of some of those adverse effects. But technically all those are still potential adverse effects. I will say that certain IVIG products, depending on their components, you can pick and choose certain products based on comorbidities or other risk factors you may have. So again, as long as you're really communicating with your provider, the risk factors you have, that I think helps a lot in deciding whether or not the risks that you have going into therapy outweigh the benefits of IVIG. Oh, and then I guess the second thing I would just say is sub-QIG, because you're not getting that instant boost of IVIG. With sub-Q, you're not getting as quick of a response. So if you're using IVIG to treat like an exacerbation of symptoms, sub-QIG may not provide the relief you need right away. Great question. Okay, so that's perfect because it brings us right into, yeah, that's perfect timing. It brings us right into IVIG products. So these products differ in terms of the stabilizers they use, the sodium and sugar levels, so salt and sugar levels, their pH and osmolality, their concentration, and the components of those 5 classes of IG. So essentially, most of it is going to be IgG, but then IgA content can also differ as well. So these products are not generics by any means. One size doesn't fit all, and if you have to change products, I won't say that it means that you won't tolerate another product. Like we said, it can actually be a good thing that we tolerate products differently, because if you're not tolerating one, we can try another one. But also keep track of what you receive and what you tolerate, because because the next time you need IVIG, that's usually a good starting place. If you know what you tolerate, that's something you probably want to stick with. But again, there's lots of factors that we know what to look for, as long as we have all of your medical history, and we can really find products that are a good fit. Sometimes products do need to change, like in the case of shortages, or maybe you're in a hospital and they don't carry the product that you normally receive. Or the most frustrating scenario is often insurance trying to mandate which product you need to receive. So all of those cases, again, there may be another product that you can substitute and you'll tolerate well, but it shouldn't just be kind of picked out of a hat. So definitely, if you have any questions or concerns when a product change comes up, make sure you're discussing it with your prescriber or your healthcare team.
We have another question, Angela. Daniel asks, when we talk about IVIG in group, we often compare it to plasmapheresis. Plasmapheresis is intuitive in that it removes harmful antibodies, but understanding IVIG is more difficult. Does IVIG have some mechanism that destroys the harmful antibodies produced in MG?
Yes, good question. It does. So IG does work by neutralizing the autoantibodies that are in circulation. So it works to both neutralize and destroy those autoantibodies, and sort of overwhelm the immune system with its other protective effects like anti-inflammatory effects. But yes, it does destroy and remove autoantibodies. I love the questions. Thank you. Keep them coming. So we're at the summary, but again, feel free to ask questions. But IVIG, so we discussed that it's made from purified IG of healthy plasma of thousands of donors, and it's given to provide individuals with myasthenia a boost of IG, which fights back against those autoantibodies and restores communication between nerves and muscles. So you may see IVIG used in myasthenia gravis for exacerbations, but also short-term therapy when we need like bridge therapy, for example, to something that takes longer to work. We also see it used in refractory patients that are refractory to other treatments. They may be on IVIG chronically. It's infused intravenously over a few hours a day, over 3 to 5 days, and it can be given in home or in a healthcare facility. And although it has side effects, they're generally mild and self-limiting. They usually occur with only the first few infusions, and after that, they either don't occur, or you find ways to troubleshoot and prevent them, including like hydration and pre-medications. make sure you're communicating any side effects or intolerance, adverse effects. There's lots of troubleshooting out there, and we don't want you to be miserable or ignore any serious signs or symptoms of reaction. Again, hydrating is extremely important, both before and after your IV infusions. And then keep in mind that although many IVIG products are available, each one is a little bit different. And then last of all, and probably most important, is just never hesitate to ask questions. That's what we're here for, and you should never hesitate to ask. So that is everything I have. If there's any questions or discussion in addition to what we already had, I'd love to see if I can answer anything.
I actually do have either discussion question kind of. So one thing that I've noticed that a lot of prescribers don't mention is the fact that you shouldn't test for specific antibodies when you're on IVIG infusions. Is that something that you know of or have heard of?
I have heard of that. So yes, depending on the antibody being tested for, essentially if you're receiving IVIG therapy, and if it was recent IVIG therapy, you've received immunoglobulins, exogenous immunoglobulins donated from, pools of plasma that aren't your own. And so when you receive a large amount of donated immunoglobulins, that can kind of have a dilutional effect on antibodies that your body is producing. So you may be getting a sample of antibodies that were provided to you from the product you're getting, but you may not get a great snapshot of what your own body is producing.
And, oh, wait, just a minute. We have another question. Not my own. Okay. Suzanne asks, hello, I'm about 9 months into IVIG, but haven't had a discernible response. When do MG symptoms typically see a response? How many months in?
Yeah, great question. So again, this kind of goes back to the beginning of the presentation. Individual circumstances mean everything. Like I'd have so many questions to find out more about the specifics for you. But generally speaking, myasthenia gravis patients that are acetylcholine receptor antibody positive, so again, the 90% plus or around 90% of patients have that, typically will see an effect within the first week of therapy. But again, there's refractory IG as well, depending on if you have other autoantibodies at play. All those things can take effect. So I would definitely say that's something you'd have to discuss on an individual basis with your prescriber.
Amanda asks, what company primarily manufactures IVIG?
Yeah, so several companies. And there's so many that I don't even list them all. But also I don't want to provide any bias and start rattling off names because really one product is no better than the other. It just depends on the individual patient and the key components of that specific product and whether or not it lines up with your individual needs. But at any given time, there could be between 8 to 10 products that the manufacturers are making, and they seem to always be coming and going. New products are always coming on the market, and certain ones are being discontinued.
Okay, another question is, Ron asks, for ocular MG for those taking pyridostigmine, when it becomes ineffective, is IVIG an alternative?
That's a good question. I would have to say that I am not familiar with using IVIG for ocular symptoms for myasthenia gravis with ocular symptoms only. That's something I'd have to look more into, but that's not something I'm familiar with.
Daniel asks, a lot of neurologists insist on testing us for antibodies while undergoing IVIG or other sorry, it keeps switching, or other immunosuppressive treatments. How do we explain to them this very basic fact that they are testing for antibodies that may not even be there? Because some neuros have been revoking diagnoses due to the lack of antibodies during treatment that removes those very same antibodies. Is there some way we can advocate or educate neuros to this very simple fact?
That's a great question. Maybe more of a discussion point than a question, because
Yeah.
I don't have the answer. I wish I did. I think, I mean, you can always get second opinions. You can provide, if you are aware of, I mean, you can reach out to, I'm sure, like the website for the Myasthenia Gravis Association has some great literature as well. You can always print that out and bring that with you. But also, yeah, just talking to probably more prescribers and just continuing to advocate for yourself. But I don't have the answer to that.
Amanda asks, she says, I was diagnosed with LRP4 antibodies. Will IVIG work for this type?
So there's variable responses to IVIG with some of the other autoantibodies that are produced in myasthenia gravis. As far as I know, it's best studied or most widely studied in the AChR antibody positive individuals. So I don't know that there's enough literature out there to support it, but I know that there are variable reports of effectiveness in various autoantibody, like those seronegative subcategories of autoantibody disease. So it's something worth looking into and asking about. But I am not familiar with that.
Linda asks, is it okay to take IVIG consistently like you might take an oral medication?
Yeah, so some patients are for it depends. It always depends. But for various indications, IVIG can be a lifelong therapy for certain patients with different indications. That's not uncommon at all in my line of work to see IVIG used forever, as long as patients are tolerating it and having a response. I think for myasthenia gravis, again, it's primarily used for exacerbations so that you can have time to get a more long-acting therapy on board. IVIG, like we said, it does carry some risks, and additionally, it's very expensive. So if providers can find something that is less cumbersome to you, like an oral therapy, something that is more affordable, those are definitely therapies that are going to be preferred in a lot of cases, not all.
Linda also asks, how long do you have to wait after IVIG to get a COVID vaccination?
Oh, that's a great question. There's been a lot of different data out there. Ideally, you would get it before, but how often can you predict when you're going to need an immediate IVIG infusion? I would say check with your provider. There's different protocols out there. I've come across several. There's no concrete answer. The CDC hasn't provided a concrete answer either. Depending on your risk factors, sometimes the risk of COVID is great enough that your provider, you may have just had an IVIG infusion a few weeks ago and the risk might still be there that they say, go ahead and get it now. Or if it's maybe not peak season or you don't have specific risk factors for COVID, they may encourage you to wait a series of several weeks at least before getting that vaccine. Just to allow your body to mount a full response to the vaccine when you do get it. I so appreciate these questions. They're so good. I love the interaction. Is there anything else I can answer for anyone? Or not answer, but comment on? So, well, again, thank you so much. It's been a pleasure, and I really appreciate the invitation and opportunity to speak to everyone. If you'd like to reach out to me with general questions, feel free to, but anything specific, of course, talk to your provider and make sure that they can evaluate you on an individual basis.
Yes, thank you. And hopefully we'll see you next month.
Thanks, everyone.